of aging in this project, we're also doing with the social aspects. So hence the term teragerontology. So I'm going to give you a little bit of background on where this idea came from and how we put it together, where we currently are in terms of the program, and then we can talk about some stuff about healthy aging. So here we go. We'll take it away now. So these are the partners that I had when I developed this. Dr. Max House, the late Lieutenant Governor, gave me the seed for this thought to develop it. And at that time, there was dementia funding coming down federally. And a group of us at the university put our heads in the think tank to come up with what would be a really good community project to help improve the care of our seniors at home. And I had this concept about dementia and trying to figure out what would be the interventions we could do in the home to optimize people to age in place and to prevent premature admission to long-term care or to the emergency department. So I've had about 40 years experience now in geriatrics. I trained in geriatrics in England back in the 70s before there were any formal geriatric training programs in Canada. And I sort of been interested in geriatrics throughout my professional career and spent a couple of years in Australia doing some sabbaticals. And that's sort of their model of care sort of made me think about doing things different in our country. So it's sort of exciting now to be involved with this 10-year vision group with government to put together a plan for seniors for the future. So we're going to be engaging our community publics to see what their thoughts are and so that we can sort of help mold the future, so to speak. Obviously, we need a greater community focus if we are to survive in the future. The institutions are basically gobbling up all the funding, so that I think the number was, I think community funding grew like 2% and institutional funding grew by 200 and something percent in the last 30 odd years. So it's a fantastic number anyway, but there it is. So here we are. This is the outline of what we're going to talk about. I'm going to talk about our demographic first. I'm going to talk about the original research. Then I'm going to talk about our program. And then I'm going to talk about models of care and how we implemented the program and lessons learned in our program to date. So dementia is a neurodegenerative condition that in later stages significantly impacts the person's ability to carry out activities of daily living. So in other words, you got a cognitive problem, but it has to affect your function. While it is not a normal part of aging, the risk of dementia increases with age. According to the Canadian Institute for Health Information, approximately 1 in 4 seniors age 85 and older have been diagnosed with dementia.
Excuse me, Roger, sorry.
Yes?
Your slides are not changing.
Oh, so I don't know.
You're supposed to be doing that, remember?
I am doing it. I am changing them here on the thing, and I'm going through the arrows, but it's changing here on my computer, but it's not changing on yours.
I believe it's because the screen is not shared.
Okay, so you are screen sharing. I'll hit that. New share. Is it, what slide is the background slide up there now in your computers?
It's slide 1 showing presentation to seniors resource
I
center.
don't know what's going on here. We got to figure this out.
So I think
Roger, excuse me, did you click on from beginning?
right.
Yes, I did.
Well, I thought you did.
Try stop share and then try to get
I'm going to stop share and try to go in again and see if I can get it to work, okay?
And Beverly is not closed captioning. You got that on auto. She's got
Okay, so share screen again.
Yeah.
You got to sign the closed captioning. I got kicked off.
You got to
And then
turn
we
that
got
off.
that.
She can't close caption because you got that on auto.
From beginning.
Yeah.
And now, do we do what now?
Can you turn off your screen so I don't want to be in the screen.
Share,
Turn off the
share
screen.
sharing.
Yes.
Okay.
And then next slide there. So before we have up higher, right?
Yeah.
So now we go in slideshow, file, slideshow, and then we hit from beginning.
Yeah.
And then
So
I guess we just go from there, right? So
what are
I'll
you
go back.
seeing? Are you guys seeing any slides now?
Mary, are you seeing any slides now? Did you see slide 1?
Yes.
I do, yes.
Now, do you see slide 2?
Yes.
Yes.
Okay, we're good.
It's not the full screen though.
That's fine. That's fine, Mary. Don't,
Okay.
don't.
All right.
Okay.
Yeah, it's a bit weird what's going on. I'm going to see if I can make the screen a bit bigger. We'll see here. That's full screen.
You know, how nice and big, but
I think I'll leave it like it is because at least I can present it now and you can see the slides. Okay. So this is our outline.
disable. There you go.
I think we're trying to figure out.
Okay. Can you see? We should be at background now. Do you have
Now
it?
I'm gonna, she's going to assign.
Yeah, okay. So dementia is a neurodegenerative condition, and you've got to have cognitive problems matched with functional decline in order to make a diagnosis. It's not a normal part of aging, but the risk increases with age. And if you make it to 85, approximately 1 in 4 Canadians will be diagnosed with dementia. And as you know, now 85, or you may not know, 85-year-olds are the most rapidly aging demographic increase in our population. So that in the next 10 years, that group should double. So that means that for the next 30 years, because the baby boomers are coming through the system now, over the next 10 years, we'll see the incidence of dementia double in the 85-year and older age cohort. And it's going to double like that for the next 30 years. Keep doubling. So as you can see, if our nursing homes are already full, and the average age in our nursing homes in Newfoundland, I believe, is 80 at the moment. And the vast majority of people in the nursing homes now are demented. So we are going to have a huge increase in our community supports if we're going to take the pressure off institutionalization. So when you look at the stats from the Alzheimer's Society, we currently have 9,600 people in Newfoundland living with dementia. By 2035, this is thought to increase up to 14,000. Advanced dementia is a strong predictor of institutional placement. These numbers are grossly low, and this was reported in 2016, 2017. Most experts in the area now say this is between 80 and 90%. Especially in later stages, people with dementia need services and supports to live their best lives. And that's the challenge that we're trying to meet with this home dementia care program. So the objectives of the program were to see if we could enhance the patient in their living environment by helping the caregiver and the primary care person involved with that patient. By enhancing their skills, we should be able to improve things. Now, we know that people with dementia end up in the emergency department over 70% of the time for 2 reasons. One is a fall, and the other one is delirium, which is invariably due to too many drugs, as the main diagnosis. So if we have an intervention that prevents falls or helps prevent falls and helps trim drugs down and optimizes their healthy environment, we should be able to prevent them from prematurely going to the emergency department. Because if you go to the emergency department in Canada and you're a senior with dementia, you have about 1,000% increase of being admitted and ending up in long-term care over the average Canadian. So the key to it is keeping those people out of the emergency department. And our modern hospitals, which are basically based on a model 50 years ago, are not designed to deal with dementia. So people with dementia are often in a hazardous situation if they end up in the hospital. So I was looking at how are we going to communicate with people? So we got to use technology. So we're going to look at how we can enhance this triad by using peripheral technology. We need to develop a method to do this, and we need to look at feasibility issues, and then hopefully take the experience that's already out there from people who are caring for people with dementia and from family physicians who are working with families with dementia, take their combined knowledge and see what the core elements are that will help us do an intervention. So pretty complex stuff, but basically, this is what we did. So we said we got this triad of the caregiver, and it's been said by the Alzheimer's Society that 50% of caring for people with dementia is caring for the caregiver. Because if that caregiver burns out, the person is destitute. So we have to care for the caregiver. And the primary care physician needs to be upskilled, or the primary care provider needs to be upskilled, knowledge base wise, to deal with the challenges that the families are facing with dementia. So how do we do that? Well, we said, let's look at physicians out there in the community and have them refer, because we're trying to enhance their ability to care for these patients. So that was our referral network. And then we'll go in as a team, do a home visit, do a comprehensive geriatric assessment, and then once we've done that, we'll feed that information back into here so that they can optimize the care of the patient in their home. So how are we going to make that link? Well, we said we'll go in and visit the home in real time, and then afterwards we'll use computer technologies to enhance ongoing monitoring and care. So we had this sort of a system developed. So in the actual study, we took 20 families across rural Newfoundland, and we gave them all for 6 months an intervention. And the intervention was a home visit. We gave them an iPad with applications for monitoring their loved one. There were 3 applications. One was a behavioral application, so we could monitor their behavior. One was a caregiver stress modification. And then the third one was a depression scale for them to enter. So the patient's caregiver in the home could fill out those apps, and then I'm remotely monitoring those apps, and I can tell when the patients are getting in trouble. So we would have a comprehensive assessment done. So we do a head-to-toe examination, functional assessment of the patient, and see what their home living environment was, and do a remote occupational therapy assessment. So we did all that stuff. So after 6 months, one group was followed by me, and the other group was randomized for usual care in the community. So this is what we had. So we had to establish the personal contact with the families. We did assessments on the patients. We recorded a video for home occupational therapy, so that way we could optimize the home environment by putting in, for instance, raised toilet seats, rails, lighting, that sort of stuff to prevent falls, and familiarize the family with iPad and Skype technology. And a lot of seniors are fearful of technology, so often we had their teenage relatives or nephews would handle the computers for us so that we could link in afterwards with the families. Okay, so these were the apps we developed. Very expensive to develop apps, and it cost about $5,000 per app. And I'll tell you what the results of that was in a little while. So, and then we did a fairly detailed analysis of what we were doing. So when we did the visits, they took about 2 hours to do a visit. And we looked at, as outcomes, did the person end up in emergency, hospital stays, long-term care? Did he have falls? Were they referred to other people? Did we reduce the primary care visits? And was their stress reduced? And then we did a whole lot of stuff looking at the patient's actual functional activity and their mental state and their physical state, and then we tracked our time, and then we did the interviews of the caregivers and family physicians. So a fairly detailed study. And what we did is we looked at communities that were rural, but far enough apart that there wasn't a crossover between the family care providers. So what we had is we had Clarenville and Buren. Buren was our control, Marystown, Buren area, and in Clarenville was our test. And then we had Placentia and Carbonear being our control, and Placentia being our test site. So what we did, we randomized the 10 families and to test, and 10 families to control in these communities. We had in the physician group 11 physicians over 200 years of experience, which was great in terms of getting concepts of care and needs for these families. So The slide is not advancing. There it is. Okay, so we had a model. The model was to age in place. We were going to support this triad, and we had primary care physician support, and we had caregiver support. And on the caregiver support side, we were going to use technology, commonly care, and try to arrange for hospice, a home respite care if it was available. And on the primary providers side, we had home visits, central coordinator, and interdisciplinary care that we'd help coordinate. And on the foundation, we had rural support, we had education and connectedness, we had government funding, and we had creating a dementia caring society. So this was the foundation for the development of a caring society. These were the ways we were going to enhance that triad, and hopefully we would be able to maintain the person in place for longer. So for the primary care provider, we're doing home visits. We would create a plan, educating the family, educating the physician, and being available at short notice for discussions when problems arose. And for the caregiver, we were looking at their altruism. A stoic caregiver is not going to quit, but a caregiver who is under a lot of stress will quit. So we had to find ways and means of reducing that stress. Financial status was important because they need money to pay for care. Background education was important because we had to gauge our education to their education level. And family dynamics were important because the daughter from Ontario could often disengage the family who were doing a good job at home. And when she came home, she'd want mom institutionalized. So we had to do a lot of education. So if we looked at successful versus unsuccessful primary care circuits, anticipatory care, dementia has a course, a trajectory, so we should be able to help the families anticipate as they go through the stages, what are the things that you're going to see in the various stages. We should be able to system navigate, and that's a very confusing thing. In Newfoundland, knowing where people are is really important, and where caregivers are, and then caregiver validation, letting caregivers know they're doing a good job, or maybe you should do this a bit different because that could be causing the negative behavior. So the things that were negative were lack of specific supports for dementia, unclear circles of care. And what we mean by that is that the people who were caring for the person at home weren't coordinated, and lack of common communication between primary care physicians and families, so that there was a lot of miscommunication going on, and that ends up often with medication irregularities, which often ends up with the patient ending up with delirium and ending up in the hospital. So a very complex game, but very, very interesting. So I'm stuck here now. Here we go. So this just shows that the two groups were the same, essentially. The one thing that's interesting about that, the intervention group actually had more disability than the control group, which should have said that we had more trouble in that group. You see at intervention, after 6 months in, 2 people had died in the intervention group, and in the control group, 1 had died. However, at the end of the study, the next 12 months, only nobody in the test group ended up in an institution. 3 people in the control group were institutionalized. And that was at 0.07. So people who are statisticians out there will tell you that's pretty significant clinically, okay? So when we look at the balance, what keeps people in their homes and what are the things that go against people staying in their homes, this is an important slide. So isolation, the more isolated you are, the more difficult it is. And with dementia, people tend to contract in their circles of care because they don't like going out, because they get embarrassed and their loved one can't communicate, they can't socialize as well. So isolation is a real problem. Advanced disability, the more comorbidities, the more disability you have with your dementia, the more difficult it is to manage. Lack of knowledge. If the families are trying to care for somebody with dementia and they lack knowledge, often they can aggravate the negative behaviors or can cause the negative behaviors. Clinging to the past. People who don't want change are stuck in a situation with dementia because things are changing irreversibly. So that's a problem. Limited resources, a huge issue. Financial stress, another huge issue. Fear of the unknown. And emotional strain. These things are hard. The emotional strain on families, because it's not just the person who's caregiving, it's the caregiver's family. but we're also stressed out. So this is very, very difficult. Often people are giving up their jobs or taking time off work, and they're stressed in the workplace as a consequence because they got to go home or stay with mom because there's nobody to be with her. On the positive side, help from family and friends is really important. Home care support is really important. And I might add timely home care support. Minimal disability. So if you got less physical disability with your dementia, you'll tend to do better. Knowledge and experience. The more knowledge and experience you have dealing with dementia, the better you can cope with it. And the sense of duty. And this is where I call the stoic caregiver. Some people, no matter what, are not going to give up. And it's very humbling to witness how the severe stress families are under with no or little support, and yet they carry on. And it's tough. It's tough. So feasibility. How are we going to bring this concept to reality? So we looked at the time, the study time. So when I'm on the phone or when I'm using the technology to communicate with these families, 50% of the time it's a medical nursing related issue. 5% of the time it's an allied health related issue. Say I need a social worker directed to do an advanced directive, or I need an OT to go in to fix a bathtub. And almost half the time it's collaborative. So half the time the physician is collaborating with somebody else in the team. So it's a very collaborative approach that we use. Then the type of contact. During the study, we used the internet and Skype applications. Skype about 1/3 of the time. That's because of the research. We were actually researching that. In real time, it's probably 10%. That's our experience now over the last number of years. It's probably closer to 10% with technology. And with COVID has really pushed the technology because it's the only way we could communicate for approximately 6 months to share. And the applications were basically not very good because a good clinician can do without the applications. We spent $15,000 to develop 3 applications, which we rarely used and which were rarely of benefit. So when people start talking the sexy applications that you're going to do, they don't tend to work. So we're putting that one down. The telephone, however, is a very good means of communication, and you can do a lot of management and follow up on people using the telephone. And you see 2/3 of the time we use the telephone. And I would say now in our practice with the 3 nurse practitioners and the OT, we use the telephone probably around 50% of the time. Key messages. Access to a remote consultative team positively influenced long-term care admission and safety. So we reduced the pressure on the long-term care system. We had patients still admitted in our program today more appropriately at a more appropriate time. The home visit enhanced relationship building and put onus on the contact of the team rather than the family necessary. This is a very interesting thing because in families, there's usually one person who's the spokesperson for the family. And depending on that person's take, they may or may not produce conflict in the family over the care of their family members when they get more advanced dementia. Where we got involved, we were looked upon as the experts. So now that was taken out of the equation. So we could manipulate the family dynamics to positively have more positive outcomes with the patient. The triage process was necessary to make best use of our time. So we needed a triage agent so we could select out who we needed. Did the OT need to go in? Did the nurse need to go in? Did the doctor need to go in? Or did a combination of us need to be involved? And then more comprehensive remote assessment is needed to capture the range of issues seen in the study patients. Now what we're doing is we've partnered with Health Harmony, and the government now has something like 1,200 patients being remotely monitored for their chronic disease. So when I heard about this, I started looking at this technology because this technology is used on the Labrador coast. And anything you can use on the Labrador coast seems to me that's something we should really look at closely. So this program with Health Harmony, we provide a computer into the home for free. You need the internet connectivity is the big problem. And if you can get internet connectivity, then we can have access to see the person in real time. We can actually do magnification views of the patient. We can check their blood pressure. We can check their weight. We can check their oxygen levels. We can check their sugar, and we can check their pulse. So now we can get their vital signs remotely. We can look at the patient remotely, and we can make clinical decisions to direct the patient's care more accurately. So this is a big jump, and COVID we have to thank for facilitating this. You stalled there for a second now, waiting for the slide to move. We're stuck. My slides are not advancing. Yeah. Yeah, okay. The CEGA, this was a remote monitoring system in Australia that I was involved in on my sabbaticals. And this is where a lot of this stuff came from. So let's see now. She's thinking. I know what it says. The next slide is a video. And that's why it's slowed down. It's taking time to load. Yeah, she's red now. Okay. Okay, sorry. So these are the training needs, and you'll see that for both the allied health and the MD and nursing, these are our training needs. So what we do is we attempt on a weekly basis to have a round and discuss these issues. So system navigation, how do you get through this complex medical system? Medications, fall risk assessment, behavioral aspects, non-pharmacological management, physiotherapy, strengthening exercises, diet and nutrition, advanced healthcare directives, medical management of depression and cognitive behavioral therapy, validation of the approach to the patient, caregiver stress counseling, validation of treatment approach, and general dementia education. So these are the areas that were coming up when we did our focus groups with caregivers and doctors as to what were the needs out there. Transition to implementation. So we had the Triad, and then we've got referrals. So we take referrals from primary care physicians, from geriatric specialists, from community health, from the Seniors Resource Center, from the Alzheimer's Society, when no primary care physician is available. We try to get the medical history, because the medical history, the primary care physicians have that. If that's not available, we'll take them directly then from the Alzheimer's Society, a Seniors Resource, or community health. Usually it's via a social worker or the patient care manager. The geriatric specialist will refer directly to us, and we take patients from them who are in hospital. We've also taken patients from them who were referred out of the nursing homes back into the community. So we're trying to make the direction go the opposite way now, instead of always being the one-stop shop to the long-term care and never return. And primary care physicians. So I'd say now about half our referrals are from primary care physicians, half from geriatric specialists, be they the geriatricians or geriatric psychiatrists, and the community. So wait, she goes red. Okay, so now we've got our administrative person, and we're getting a new administrative person. This lady's gone to a permanent job, but she basically is our triage agent. She actively looks at the call list, and she makes sure that we're checking in on our patients no less than once a month. She goes red again. I'm sorry about this, but this it was a fairly complex presentation, so that's why it's taking a little bit longer for it to load. I have to wait for the slide to go red so I can advance. Yeah, it's slow, yeah. Yeah. We didn't see this when we went through the original, but I guess where there's a lot of people online, it's requiring more power. That's how I would figure it out. But anyway, we got Mary, yeah, she's moving again now. So this is the triage process. And then, so patients could need to be linked in with community sports, community health nurses who are trained to do the comprehensive geriatric assessment. We have allied health people in the community that we need, nutritionists, a dietitian, social worker, and we got geriatric specialists. So we got all these people out there working for this patient up here. So how do you coordinate that? Because these people, if they got to try to coordinate it with their family doctor, are lost. Like if you try to get into a doctor's office today and you're on the phone trying to book an appointment, how long does it take you? 20 to 30 minutes is the answer. And if you got 4 or 5 people you're trying to coordinate, most people haven't got time to do that. So we're sort of developing circuits within the system so that we can get priority access to coordinate things. I'm sorry, this is slow. I'm waiting for the system to load. How are we doing for time? Yeah, I want to go too fast here now. So, Mary, this is really strange, eh? So this is the how we communicate. We got an active electronic medical record that all of our team members enter, and that's accessible through the geriatricians as well. And we have our comprehensive assessment. And we were going to use Jabber, but Jabber was too complex. So we're using a platform called Health Harmony. Oh boy, this is painful. Mary, I'm going to try to whiz through some of these next slides. This is, I didn't realize we were going to have this happen.
But that would be a good idea, Roger. I'm being mindful of the time here.
Yeah, I know,
And
yeah.
how much time people have.
Yeah, I think what I'm just going to whiz on through the slides. This was a home video, but I'm not going to show the video. These are goals of our program, but basically you've heard that. What we do is we go in with the physician and the nurse practitioner. Generally, we'll do a home assessment, or sometimes the nurse practitioner, if the patient has been seen by the geriatrician, will do the home assessment. And we have our OT who goes in and does a home assessment, either locally, remotely, or in consultation with another OT in your region. So these assessments will be completed to support the client. And then we carry on. If you're greater than 45 minutes from St. John's, we do a remote monitoring after our initial visit. So if I go down to Buren, drive down to Buren to see a family, which I've done, to do a home assessment, then we will put the computer system in there before we go down, and then we will follow up using the computer and then liaise with the family doctor and the caregiver via that method. So initially we were going to have 100 clients in their first year. We did that. And then in year 2, COVID came along. We were hoping to be up to 300 patients by year 2 and be in central Newfoundland with 2 more nurse practitioners. Unfortunately, that didn't happen. And COVID changed everything, put everything on hold. And then we had the usual stress of an office with COVID. So we got down, we are over 150 clients still in year 2. And now we're moving out to central Newfoundland and then later to western and northern. So they're currently now in the process of hiring their nurse practitioners for central, and I'll be involved with the doctors out there and the nurse practitioners that's setting their program up sometime now early in the new year, we hope. So how do you get into the home dementia care program? Well, you need to be referred. You need to have your dementia worked up so that the diagnosis has been at least some preliminary work done on it. If you're rural and remote and your family doctor has done what he can do, then it's quite appropriate to refer to us. Sometimes when we get a referral, we refer them on to the geriatric psychiatrists or geriatricians because they need further sorting out. And I'm trying to reserve our time so that we look after people with moderate to severe dementia. So we got people with well-established dementias who are running into behavioral problems, because that's where you can get the most use and most benefit from our team. We've taken people who are in long-term care. We've taken people who are on the wait list for long-term care. We've taken patients out of hospital who had deliriums, and we followed them where they had nobody to coordinate the care in the homes. So we did that. We've taken people from alternate levels of care in the hospital back to their homes. And we've taken chronic disease, frail clients with cognitive issues back to their homes. So personal care home or long-term care facilities with active planning for a client to return home, it's a good idea to get us involved. Our intake, we have a number, 777-2462. If you call that number, we can direct you and triage you appropriately. These are the lessons learned. We're better with the more advanced types of dementia. Our program works well. We can discharge early, get people out of hospital early. We can prevent long-term care admissions. We can reduce your falls by a multifactorial approach. We have a social worker. If we had a social worker attached to our team, that's what we hope to get in the future. I think we've become a lot more efficient. So far, we've reduced the emergency room utilization by every patient that's in the program, which is 132 now. We have 1.2 less admissions to the emergency department per year, which is a huge saving to the system and to the patients, even more so to the patients. Come on now, next slide. When I hit that and it doesn't, and I hit it before it turns red, it slows it down further. Right? Okay. I only got one more slide, Mary, then I'll just talk a little bit about healthy aging. Okay, here we go. So this is an important slide because there's some stuff here that's going to really get people's dander up. We've reduced our long-term care admission rate. 32 of our patients in the first year died at home versus only 27 going to long-term care, of which half were referred to us initially on the long-term care trajectory. And that's over 18 months. And when you look at that, when you consider that 90% of people with dementia die in institutions in Canada, that's a phenomenal statistic. Also, we palliated our patients at home. So of those, the majority were palliated at home. Some went to the palliative care for the last 2 or 3 days of life. And I think these were quality deaths. When I say a quality death, the families were well supported and well prepared. Personal care companies, I'm making a statement that they need to be regulated. There are regulations for these companies, but they don't seem to be being enacted upon. These are some of the things we've seen over the last year and a half. We've seen abuse. We've seen managers of these companies, what I would say, abuse primary caregivers. We've seen timesheet altering by workers. We've seen companies threatening families who are about to terminate their services by charging them. We see no formal dementia training for workers who often make the situation that they're hired to go in to help worse. We've learned that the video consult is enhanced by our going in and doing the home visit. We had, when I did this slide, initially 22 patients. We have 25 now being monitored remotely. You can see these are high needs patients. We average 2.33 contacts per month. Over the last 18 months, we've had 2,822 patient contacts for 132 patients. And that involved 1,212 home visits. So we do a lot of traveling. We're busy. We aim to try to bring the service to the patient in their homes. And this is at a tremendous saving to them in travel and time. So I'm going to pass this back to Mary now before I take some questions. But the last thing I'm going to say is that if you want to age well, there are 3 things you have to do. And COVID has taught one of these in spades: socialization. Socialization is very, very important for healthy aging and is very, very important for your brain. Okay? We're humans. We long for human contact, human emotional contact, human needs. So that's a really important thing. Nutrition, and hopefully nutrition is getting better in Newfoundland because we found, at least during this COVID, we could still get food on the plates, and we had our grocery stores were relatively full. But good nutrition and getting fresh fruits and vegetables and that sort of stuff is really important. And hopefully out of COVID, maybe we're learning that going back to gardening is not such a bad thing in Newfoundland. There was a time in Newfoundland when we all had our gardens, and growing your own vegetables and knowing what's going in the soil is really important. And nutrition, exercise, the third thing. And exercise, aerobic exercise, and if you can walk, or if you can crawl, if you can move a wheelchair, or if you use a walker or an aid, movement is important. If you rest too long and not move, you will die. There's a scale of frailty developed by Dr. Ken Rockwood, and you see the patient erect, the patient bending over, patient going to a walker, wheeled walker, then from a cane to a wheeled walker, to a wheelchair, to a bed. And life is like that. You have to move to stay alive. And we got to start looking in our society, in a dementia-friendly society, how do we encourage exercise and movement in our seniors? How do we design our shopping areas so that they're senior friendly. You know, walking programs, even having covered areas that you're not going to slip on to connect between stores, et cetera, et cetera. These are sort of things. How do we make our transportation system? How do we have our busing system so that seniors can get access? How can we get groceries into people? How can we get home repairs done? These are the things that are important. So mobility is important. A familiar environment. I think the one thing about aging in place that's so important for seniors is the familiarity of environment and the support structures that that environment has developed over the years you've been in that home or the place where you stay. These are really important things. So with that, I'm going to leave it open there for questions. So I'm going to sign back to Mary, okay? So I'm going to stop sharing, and I got to get out of here now.
Thank you, Roger. That was really informative. And it's too bad we have those glitches there as we went through, but I guess that's technology for you sometimes. I don't have any questions in the chat box, but there were some questions that came in earlier. And one is, how do you best assist if a person is recently diagnosed with dementia? How can the family assist that person in dealing with the diagnosis? Because that's really important too. I can imagine, you know, people, if they're diagnosed, all of a sudden they're hitting face with a diagnosis of dementia. It has to be a difficult thing to accept. So how can family members help that person to deal with that diagnosis?
Yeah, our society is starting to develop programs, and the Alzheimer's Society, I think, is your first go-to. The Alzheimer's Society has a program called the First Link program, in which we're all of us participate in that. And it's a 15 session program, which runs for about an hour and a half. And you can log in on your computer, or you can actually go to the Alzheimer's Society and sit in on these meetings. And they take you on the total journey through dementia. Now, the one group that find that difficult is the young dementias, because the young dementias have some characteristic things that are a little bit different than the older dementias. Now, 95% of people with dementia have the age type, the older age group associated dementia, okay? The sporadic type of dementia. But the familial type of dementia is a different character and tends to be more aggressive and hit people much younger. So that almost needs more specialty involvement. When I say specialty involvement, the Alzheimer's Society, yes, get involved with the Alzheimer's Society, but also seek out support with these more aggressive forms from either your geriatric psychiatrist or your geriatricians, or even us. We can help you sometimes with that, okay? Because there are more complex issues when you're dealing with younger kids with parents with dementia, right? With a parent with dementia. So that's a different kettle of fish. But that's a rare kettle of fish, relatively speaking. You know, we're talking about the sporadic form, which occurs after age 65, and that's the one that's going to be so prevalent in our society. So early on, Alzheimer's Society, early on, talk to your family doctor or your primary care provider, your nurse practitioner, because they will have information about early diagnosis. So once you have an early diagnosis, then you need to start talking to your family. And I would, at that point, start thinking about planning your future care. How do I want to be treated? What respectful things do I want in my life that if I end up in the system, how do I want to be treated? So that we call it advanced cell care directive. So you want to have your will straightened out. You want to have your power of attorney, because if you lose your ability to do your finances, you have to have somebody to kick in to do that for you in order for you to stay in place, right? So these are sort of things that we talk about, and I think that gives you a chance to prepare. And the earlier that we'd like to get a real early diagnosis with dementia, so that you can be involved in your care of your wishes. Dementia is a chronic disease. It's not going to happen. You're not going to die tomorrow with dementia. Dementia goes on for years. Okay, there is a trajectory. There are drugs that can work early on, so you need to know about those drugs. Those drugs have a modest effect, but in some patients, they can actually delay the symptomatology and improve your outcomes for a limited period of time. Later on in the stages of dementia, we have drugs that can help with the behaviors, the negative behaviors. But the most important thing that I've learned over the years dealing with patients and families with dementia is to ask, when you see a negative behavior, what is the patient trying to tell me? They've lost some sensory capacity, so they're miscommunicating. So it's either they don't understand the language, their vision is off, their balance is off, they got limited depth perception. So their world that they see outside is different than the world we see, and the behavior they're giving is because we're miscommunicating with them. So it's really important to have you need to get knowledge about behavioral interventions. If any of you are YouTube fanatics, if you go to UCLA Dementia Care Program in the US, they've developed a series of about 60 videos which run for between 5 and 10 minutes, and they address virtually all the negative behaviors that you see with dementia, and they also give you techniques on how to deal with the common day-to-day things like washing and bathing, safety around the home, these sort of things. And they give you examples, and they show you role plays of how things can be managed better. I'm going to leave. I got some other people around me, so I'm going to ask if they may want to contribute in some points as well.
I think you covered it.
The only thing I'd like to add, there I am. The only thing I'd like to add, I'm Carolyn, the OT, is that the diagnosis doesn't mean life is over, that you still have interests, and the person has so many abilities to continue pursuing those interests. And that's when and they're so important at this time, because that taps into who that person is. So finding ways to help that person engage in the activities that they find meaningful is so important. It might have to change the way that they engage in them, but it doesn't mean it's over. And there are some very inspiring and videos and books about people who have dementia and talk about how they continued living with dementia. So those might be some helpful resources for someone who's newly diagnosed. And maybe, that it's a really good idea. The question has made me think we should put together a little list of some of those resources. So I'll do that, and I can send that along to you to share.
Great.
That's fabulous. Actually, add in the name of the YouTube site for the dementia videos. And if you could send me information like that, I'll put it out to everybody who's on this call.
Great. There's another program that's coming down the tubes. The Alzheimer's Society are developing a passport to dementia program, where now I think it's probably going to be, I think the government is subsidizing it for a small amount of money. People are actually getting trained on the behavioral aspects and how to deal with the behavioral aspects of dementia. So great, at least now we've got an educational resource that's out there that we can actually start training these people out there in the community, right?
Yes, we're a minute running late now. That's too bad, because I'm sure we could talk about this for another hour or so. Just one quick question before we leave. I look at family members of people who have dementia, and some of them are so stressed, and and they feel guilty if they want to take a break, that kind of thing. Is there any supports out there for family caregivers?
Yeah, there's respite is something that comes to mind, and unfortunately COVID has really put the kibosh to respite, which has really been hard on families, because the caregiver needs the break to get out. Home support services is really important. That's why we got to have good, well-trained home support workers, both in the private sector and people who want to go and hire somebody privately or with these companies, right? So we got to get that training out there, and that's what takes the pressure off. Also, families got to realize that when they got a sister or brother who's doing most of the care, just being there for them and letting them know, maybe where I would go home and be watching TV, I'll go in and spend an hour with mom or dad and give my sister a break. Because try to share the load. We all have busy lives, right? But sometimes the primary caregiver just gets stuck, and it might be that they're not married, or they're single, and the family say, well, they got nothing better to do. But yes, they do have other things they want to do. they have a life as well. So I think share the burden. If you share the burden, the evidence shows that people do better. And I guess share the joy as well, because you can look at it two ways, can't you? And, you know, I see a lot of joy that people have in caring for their loved ones, but it's when you get into more advanced stages and you got to deal with the activities of, you know, the bodily activities from bathing and cooking and having to wash and clean, that's when it gets physically hard. And but there's no two people alike. One person has that and has no stress, and another person has a whole lot of stress. So I guess it's a very individual thing. But as family members, I think we need to pull together on this one, and that's about all I can say. And who am I to judge when somebody goes to a nursing home? You know, that's very individual, and sometimes the patients themselves don't want their family to be burdened by them, and that's their wish. So we have to, you know, having that discussion early on in the course of dementia is so important. If you have that bit of good fortune to be diagnosed early enough that you can actually make those decisions.
Well, thank you very much, Roger. I really appreciate that. That was really great.
The family support with the Alzheimer's Society, they have family support systems, so don't forget that.
Yeah.
Yeah.
Sounds good.
And you guys.
Thank you, everybody, for joining us today. It was absolutely fabulous. I really am, I'm pleased with the turnout. And stay tuned for more Let's Talk sessions. And hopefully we will have the technology totally laid down after another 1 or 2 sessions, maybe. Anyway, next Tuesday, we're going to do a feature on the programs and resources of our public library systems across the province. And coming up soon, we're going to be talking about seniors and mental wellness. And that's about it now for today. And again, thank you everybody for participating.
Don't lose it, will they?
Yeah, don't lose it.
The top.
I saw